Good morning, friends. My name is Delon Human. I'm a physician and I've been involved in harm reduction in food, drugs, alcohol, tobacco for some years. You see the grey hair. I was hoping to work myself out of a job, but as you all know, we still have some way to go in most countries of the 194 member states of the World Health Organization. This morning, though, we are delighted to welcome you here, hosted by the Oral Nicotine Commission, which is a group that we founded about 4 years ago, especially when the use of oral nicotine pouches became much more prevalent in so many countries. So the Oral Nicotine Commission, along with several other partner organizations, wanted to put together a short report, first of its kind, on the connection between oral health and tobacco harm reduction. Now you might notice that this looks like an oral cavity, so that's why we're here. We are right in the mouth. And you'll see as part of Mihaila's text, there's one memorable quote which says, "Les dents, c'est la vie." The teeth is the life. And in many ways, that's exactly right. So I would want to welcome you here for the next hour and 15 minutes where we want to introduce the report. We will ask Professor Mihaela Rescu from Romania, we will ask her to give us an inside view of the mouth. Day to day, she sees people who smoke who come in with oral health issues, and day to day, she's helping them with one of the tools of harm reduction to improve their oral health outcomes. So Mihaela would speak, and then Dr. Amalia, a professor from Indonesia, she will speak to us by video. She's one of the co-authors of the report. And then we are privileged to have Martin Cullip here, who's been a fantastic consumer representative in the UK. He's done a fabulous job. And we have him to be the voice of the consumer and to recount how things have changed in the UK. And then we'll have a short panel discussion, but what I'm really looking forward to is that we'll have an interactive discussion at the end. There are some experts in this room, and I know you, and we would love you to ask questions, make comments, and use this as your meeting. This is really your meeting to look at oral health as what many would say the orphan of public health. To look at oral health and to see why tobacco harm reduction is particularly suited to oral health. Bienvenue, asseyez-vous. So we have guests here from all over the world, and we are thrilled to see you. And what I would like to start off with is just I've introduced Mihaela, a professor of dental and oral health in Romania. Professor Dr. Amalia holds a similar position in Indonesia at the University of Padjadjaran. Martin is from the UK, and we'll tell you more when he speaks about him. Ricardo Pelosa is one of our co-authors, and I just wanted to make sure that you know of some of the co-authors. Ricardo is important. He's a physician, works in Italy, but has also spearheaded a program in Indonesia on oral health. And then there are several other professors who are co-authors of this book. Professor Dirk Siebold from Germany, who's a periodontologist, a gum specialist. We have Ian Chappell from the United Kingdom, who would have been here, but he's operating all day. Alice Citone from Italy, who's a professor in dental hygiene. And then Professor Cristian Cumpata from Romania. And then we also have a professor in internal medicine from India, Anup Misra, and Dr. Abbas Raza, an endocrinologist from Pakistan. So all in all, an outstanding group of authors looking at this issue, which is how can we transform oral health, make it accessible for all by using tobacco harm reduction. You have some copies of the printed edition, but you'll also find the digital PDF with all of the authors online as we speak. So when you look at tobacco harm reduction through this lens, we wanted to make sure that we combine the policy, the science, the patients and consumers, and the products that are involved. So we've looked at the current oral health governance. I'll say some words about that. And then focus on the benefits of harm reduction for oral health. That's really what this is about. If you speak to your politicians at home, they don't want to hear long scientific stories. They want to hear what is the benefits at population health level. If you speak to your patients, they want to know what is the individual health benefits. So the whole report is written in a way so it can be used by advocates. And then we've looked at a few country case studies, and I'm delighted that Dr. Hiroya Kumamaru is here from Japan. We did a study together on lives saved through harm reduction in Japan. I'm delighted that we have people here from Sweden. Fredrik is here from Sweden, which is a fantastic story. We'll refer to that in the report as well. And then we have several of our colleagues from Southeast Asia, where we know the burden of oral cancer is the largest. Now, if you look at this picture and ask, well, why is dental health important? We always see the missing tooth, but the guy also has one eyebrow missing. And in a sense, that's exactly what this report is about. Is if we want to improve the oral health, let's look at the bigger picture. Now, it's very interesting. If you look at a definition for oral health, then probably the World Dental Federation's definition, which is a not-for-profit organization, but I thought that their definition is actually pretty representative. Because oral health is not just the absence of disease, but it's a multifaceted concept, and it includes the ability to speak, to smile, to smell, taste, touch, chew, swallow, and to convey our emotions. We say hello, we sad through our mouth. So in many ways it is true that les dents c'est la vie. So please look at that and from your perspective see how we can improve this message as well. You'll see a lot of tooth and teeth today. You want to look like the teeth and gums on the left-hand side. You don't want to look like the teeth and gums on the other side. But Mihaela would tell you, the mouth is wonderful because it's the first place where you see results quickly. If you introduce harm reduction to people who smoke, they go from looking like that to a much more normal oral cavity. And then the reason why we've hammered on risk differentiation in the report is that's what politicians generally don't understand. They tend to want to develop an equivalence between cigarettes, combustible tobacco, and smoke-free nicotine alternatives. So we want to hammer the point that cigarettes on the right-hand side is the 100% harm, whereas
recording in progress.
So whereas the patches, oral nicotine pouches on the left-hand side are many-fold less harmful than cigarettes, and consumers and patients need to hear that. You'll see this graph in more definition in your report, but this sums up our whole point. This is a graph of the prevalence of oral, lip, and cavity cancer in Belgium and the EU. If you look at the purple line, that's Belgium. If you look at the green line, that is the EU. And if you look at orange, look at our friend Fredrik, that's Sweden. So Sweden, with 40, 50 years of harm reduction in action, that's the difference between the EU and Sweden. It's just so obvious that you can't understand why snus and oral nicotine pouches are banned in so many places in the EU if that's the end result. We've also looked at a few case studies. Now Japan, Hiroya will tell you, over the last 5 to 6 years, cigarette sales have dropped by 51 to 52%, which is dramatic. It's never happened before. It's a public health miracle in action, and that's why we highlight Japan in this report. We're in the United Kingdom, and we know that they now have about 12 years where they've allowed harm reduction. And the United Kingdom was one of the first countries who actually recognized harm reduction as part of their tobacco control policy, and then allowed for these products to be available and accessible to consumers on the high street in a regulated framework, which is extremely important. New Zealand has also done very well. They used mostly vapes to get their smokers to stop smoking. And then Southeast Asia for oral health is absolutely crucial. If we were able to sell harm reduction to the Southeast Asian governments, oral cancer, of which 90% is prevalent in Southeast Asia, could become history. If you look at the back of the report, we have a few specific recommendations. Number one, encouraging risk proportionate regulation. Number two, making sure that we activate the health professionals to tell their patients more about harm reduction as a means to get out of smoking. And you know as well as we do that there's still a great deal of misperceptions. Most physicians, 70-80% physicians, still think that nicotine is the cause of cancer, which is not true, and also linked to chronic obstructive pulmonary disease, and we have to fix that. That's just not acceptable. Thirdly, we've asked for strengthening alliances with our consumer associations. That's why Martin is here. And then we wanted to make sure that local research is done, because most politicians don't want to hear what the Royal College of Physicians in the UK said. They want to hear what did the University of Padjadjan in Indonesia have to say about this topic. So local research is so important. That's why this international group is such a blessing to us, because all of you will go back to your countries and you would be able to do more research and maybe tell this story in your own words to your own politicians. And we might get to a point where they accept it much sooner. So that's the report. I would urge you to download the digital copy so that you have it with you. Please send us any comments that you might have. And we will be translating this into several languages. And over the next 6 to 12 months, we will be sending this to as many politicians as possible. Up to COP11, which is in Geneva in November next year. So this is part of the story that we will be presenting to policymakers. All we're asking them is, when you develop policy, make sure that it's based on evidence and that it's not based on some misinformation or philanthropically funded anti-campaign, but open your eyes, look at the data, and then make up your mind in terms of policy. It's now my privilege to introduce Professor Mihaela Rescu for her introduction of this report. So you press the down button and then it goes to the next.
Yes, okay, thank you. Good morning, everyone. Thank you, Dylan. Thank you for your nice presentation, and thank you for inviting me. I am honored to participate in this as a co-author in this report. It's the first report on oral health, on tobacco harm reduction effects on oral health. And I think it's, let's say, just an historic moment when we can show that innovation can bring us a lot of good things, and that we don't have to demonize the things that appears as a new product, sorry, as a new idea, and we have to take care to use them if they are in our benefit. Just I want to tell you a few words about the oral cavity that you might don't know. Except for the thing that the oral cavity plays an important role in the body's management, because as Dylan said, it's the first segment of the digestive system, and it is also the place of first impact that comes into contact with different ingredients from food, liquids, drugs, and tobacco. But the oral cavity operates, like all the other organs, by the reflex rules. So that means that Each particle in contact with the mouth acts as a stimulus on the taste, tactile, temperature receptors. So even a low-intensity stimulus of the oral cavity is capable of changing the body posture. I'm sorry, the body posture or the body health. So it's not a joke when we say the teeth are life, like Davo Kubi, a doctor said, les dents c'est la vie. It's not a joke because if you know, each segment of our each segment of our body correspond to one teeth. It's just something that is already related in some scientist research. So the correlation, it's much, thank you very much. The correlation, it's much higher. I mean, the nervous system, it's very nice correlated with a very fine and subtle correlation with all the other organs. Just a second, sorry. And that's why when we have a problem regarding the oral health, we might find some other problems at the distance related to this. So, for example, we know about the calculus. All of us, maybe we have to go to the dentist sometime just to clean our teeth, let's say like this. It's the most, let's say the dentist says it's unpainful, but sometimes it's a problem. But you know, from the oral health point of view, the permanent existing irritation provided by dental calculus is not compatible with a good immune balance in the mouth. So that means the mouth, it's always fighting for the defense, for the reflex defenses, and that means in time some irreversible anarchic structure. And that's why after a very long time of this kind of stimulation, irritation, long time irritation and calculus, we might have some inflammation and deep inflammation. And as Dylan said, you can encounter some other problems like periodontal problems or discolorations or, let's say, tooth loss and something that bothers us. And also, if we think about the oral cavity, it's another point that we can say that the body posture is also influenced by the oral health. For example, in smokers without good oral hygiene, the teeth full of calculus, cavities, and constant irritation of periodontal tissue will inevitably lead to general disorders transmitted via lymphatic vessels. So that means reactions of various organs. And let's say the good part, when a person stops smoking, all the nociceptor stimulus and oral inflammation will decrease. So the reflexes triggered by these types of stimuli are discontinued. So what is the reaction of our nervous system? Is not releasing chemical mediators and the organs are relaxed, so the health must be restored. So it's up to us to restore as quick as possible if we find out that we have some problems in oral health, to restore the oral health, because that means we can easily restore the entire body health. So that's why I entered in this oral health activity, let's say. I studied the impact on oral health of this kind of products these kind of products that are not exactly the combustible products like the cigarettes, because I saw many times a lot of my patients with these kinds of problems, and sometimes they said, look, I would like very much to stop smoking, but I cannot. So, and we have several therapies in our dental activity, in our dental office activity, that needs to stop smoking, because the vascular dynamics, it's changed when the person is smoking. So sometimes we have to help the patients, and how can we do this if we don't have another tool? You know, usually when something innovative appears because it's a need. It's a need, so we don't find an alternative if we don't need it. So that's why I think the tobacco harm reduction is something that appears just because we need it. Like, let's say, a very basic example, the powder milk for the breastfeeding mother who cannot give milk to her baby. So it's not, I mean, we don't think about the entire advantages of the mother milk, but the powder milk will help us to help the child to grow up. So this is, I mean, the tobacco harm reduction is giving the unique opportunity to help these kind of patients who needs, for example, surgery, who needs extraction, who needs some periodontal therapies. All of these kind of therapies, in time, they need some let's say, steps of healing. So if the patient is smoking, he cannot follow the normal steps of healing. So the body will not help him to have a long-term successful therapy. So from this point of view, as a dentist, only from this point of view, I'm telling that the tobacco harm reduction, as I saw by doing my research, it's a very good opportunity to, and a very good tool in terms of changing the oral health for the smokers, and in a way to reach cessation. Because I had some patients who started in the beginning with tobacco harm reduction products, with some other products that they decided to use as an informed consumer. And in the end, they find out that it's a better thing for them to reach cessation. So this is the final goal. And the best thing is not to smoke, so to quit smoking. But there are so many adults that are trying, but they cannot, are willing, and they cannot quit smoking. So for them, we just try to use this alternative. So I would like to present you some of the research because, as I told you, the innovation, it's something with the aim of quality improvement. So we don't have to blame anything about what is it innovative. Let's pay attention of something that it's innovative, and maybe we can use it in our benefit. So I will show you something very easy to explain for you. I mean, a picture says always much more than words. And if you just see how it looks, an image with a smoker at first visit, before cleaning, and after cleaning, and after 6 months of switching, I mean, we are speaking about patients who decided to quit smoking or to use a product just to improve their health, oral health. So what did I do? I told them, you have to stop smoking for this kind of time, this kind of period, like 6 months, 9 months. And after that, we can start from zero, and we can examine the oral cavity after 6 months and after 9 months for all the people who are stopping smoking and switching to another alternative product, or the other one who is continuing smoking. So what I found out in the end, I will show you some initial visit and after 9-month visit for a non-smoker. Look, it's quite similar, the image. And for a smoker, look at the initial visit and after 9 months, if you can see the deposits. If they switch, you can see also that the calculus are less, and I can tell you that the patients are less, they don't have so much halitosis, they feel better, the inflammation decreases, so it's okay. But if you compare just a non-smoker after 9 months, a smoker, and somebody who is switching to tobacco harm reduction products, in my case, heated products, tobacco heated products, you can see a very big difference. So look, the non-smokers are keeping their hygiene as normal. The smoker is keeping his hygiene as normal, and you can imagine the deposits, and imagine that the calculus are having inside nitritis and nitrosamines and all the things that the combustion is bringing to the mouth when you use the normal cigarettes, the traditional cigarettes. So it's not that we are inhaling, it's not that it's impacting our oral mucosa and our, let's say, oral cavity segments. The problem is that it stays there, and it always comes to our lymphatic vessels. So that means it always poisons something at the distance. You never know what, and you never know when your immune system is down, where it's going to be a break. So, and somebody who's switching from traditional cigarettes to heat-not-burn products, and in the end, look, after 9 months, they had less calculus, less inflammation, and you know the calculus are very easy to treat, let's say, to clean, and the patient is much more satisfied because it's much more unpainful. So we don't have to say, look, it is unpainful, so let's go further. And we all know that it's not exactly quite unpainful. Another study, it's about the person who needs implants. You know, all the person who needs implants, and especially smokers, they need it because they had, you know, it's like something, it's a punishment when you don't treat yourself at the right time. In the end, you have to pay more and to do more for yourself. So if we have to pay attention, look, if we try to see a comparative bone resorption in smokers, and if we find out how the smokers switching cigarettes will have no bone resorption, look, you can see the, I don't know if you see exactly this dimension after intervention. So that means we don't have bone resorption. That means a very good thing, because it's a failure if you, for example, do an implant treatment, and in the end, in, let's say, 2 years, you are smoking again, you are continuing smoking, and in 2 years, you lose the implant, you lose the bone, and you have bigger problem than in the initial visit. So for this time of the osseointegration period, after the first surgery and the oral rehabilitation, we have to explain to our patient that he has to stop. And if he cannot stop, he has something else instead. So he can just use some other products. Just we have to explain to the patients which products we have and what kind of innovation we have another knowledge about this kind of innovations, and he will choose just like an informed consumer. Also, the vascular changes are very easy to observe now with Velscope. It's a tool that will examine very easy with a fluorescent light what kind of changes may appear in the oral mucosa. So this is something else that, for example, in smokers, in the initial visit, we found some modified buccal epithelial fissure and some atrophic mucosa after 9 months. So in smokers, all the lesions are going further. So they don't stop just because you tell them, please don't smoke. They smoke. They don't see like we see this kind of images, and they cannot analyze this kind of images. But what we can do is it's our, let's say, opportunity as a dentist to examine quickly, because if we think a little bit, how long it takes until the liver reacts, how long it takes until the lungs reacts, it's a very long time. But if we examine the oral cavity, it's very easy. You open your mouth, you use a very nice fluorescent light, so immediately you can take action. So the call for action in this report speaks for itself. It is something that we need to use if we know about it. So the biggest problem in this oral health professional is the knowledge. They are not aware about what they can use. And there are many, many situations when they cannot explain to their patient anything because they don't know for themselves. So I think a training or just, let's say, making them aware of what we have and what we might use, it's very important as a tool for the next, let's say, next oral health strategy. I told you that it was something in smokers, but when you switch, what's happening? For example, in the beginning, you can find a modified vascular design, but after 9 months, you can see an improvement of vascular design. That means it's a good thing. It's exactly as I told you at the beginning. When the stimulus, the nociceptor stimulus is stopping, then all the steps in destroying the oral mucosa are stopping. So we have an oral health an improved oral health. So I saw a science-based policy call for these preventive measures, and I enrolled myself in this. And I was thinking that we had this nice scientist without tobacco harm reduction in that era. So if they knew about tobacco harm reduction, maybe they had this opportunity to tell us more about their discoveries, their, let's say, science discovering and everything, so we could use their knowledge for a longer period of time.
Thank you. Perfect.
Thank you.
Thank you, Mihaela.
I can tell you more, but it's enough for today.
We were all in the dentist's chair.
Okay, thank you.
So, friends, the next author to speak is Dr. Amalia. She is teaching in Indonesia, so we have this video that she has sent for us.
Hello everyone, I'm Amalia from Denta Faculty Universitas Pajajaran, Bandung, West Java, Indonesia. I am a dentist, lecturer and researcher. I am actively involved in advocating tobacco harm reduction in Indonesia. The detrimental effects of conventional cigarette smoking on oral health are already well known, from benign to life-threatening diseases such as discolorization of teeth and dental restoration, bad breath, taste and smell disorders, impaired wound healing, periodontal disease, short-term and long-term implant success, oral mucosal lesion such as smoker's melanosis and smoker's palate, and potentially malignant lesions and oral cancer. Smoking is still a problem in Indonesia with a high number of consumers. Approximately 57 million smokers in Indonesia, comprises of 63% of men and 5% of women reported being smokers, a total of 37.6% of the whole population. Recently, alternative tobacco products are gaining popularity all around the world, including in Indonesia, such as heated tobacco products, vape, and snus, and it is claimed as less harmful or reduced risk products. But who knows? Is the evidence convincing? Studies carried out in dentistry evaluating the smokers who switched to alternative tobacco products or combustion-free nicotine delivery systems revealed that they demonstrated a reduction in the prevalence of micronucleated cells in buccal swabs, indicating that switching to alternative products may lower the prevalence of oral cancer. Smokers who switched to alternative products had no discolorization of teeth compared to those who continue to smoke, and the gum of smokers who switched show improved gum response to bacterial plaque challenge compared to those who continue to smoke. In addition, smokers who switch to alternative products tend to have lower plaque accumulation than smokers who continue to smoke. Unfortunately, there are still significant misconceptions about nicotine and tobacco harm reduction among both physicians and the public in Indonesia. As a researcher and educator, I recommend that the stakeholder or the authority or the government apply evidence-based policy. These alternative products may benefit us in decreasing the prevalence of oral diseases related to smoking, as well as helping smokers who are unwilling to quit or are not able to stop.
There you heard from Dr. Amalia, who works in Indonesia, where in Southeast Asia, 90% of oral cancer prevalence is present. And that is a staggering statistic. So harm reduction is really a good fit for that region as well. So thank you to Amalia. She sends her regards. And she ended her talk by talking about stakeholders. And the one stakeholder group in all of public health, no matter what the topic, that is usually treated with the least respect is the consumer and often the patient. And we've tried over so many years, and I know Tiki at WHO tried his best, Hiroya in Japan, Frederick in Sweden, so many of you have tried to give the consumer a voice. And I'm delighted to introduce Martin to you to give us the voice of the consumer on oral health in the UK. Please, Martin.
Hello, thanks. Yeah, I'm a consumer advocate. I'm not an expert on oral health, but it was interesting reading that report because I'll introduce myself. This is me, Martin Caleb. I used to be a smoker. I smoked for 33 years, and I was a very enthusiastic smoker. I loved smoking. I'd never made a single quit attempt because I enjoyed tobacco and I enjoyed nicotine. And then I accidentally quit, basically. I tried vaping products. I've been writing about vaping products for 15 years now. My first article I wrote was in 2009. And I just switched over to them without even trying. I mean, that's the great thing. I'm not the only one either. There's many who are called accidental quitters who do that route without really trying hard. But that's my story. But the thing is, there are a lot of stories. There are 1,000 stories. Every person who switched to one of these less harmful products has their own story. I went to Panama early in the year. Dr. Rohan was there, and we were there to put on a conference for consumers. And we held a session where we just invited people up at random and said, "Tell us your story," and all their stories were different. Everywhere in the world, we had people from Mexico, people from Southeast Asia, people from America, and all their stories were unique to them. And consumer groups in Southeast Asia and in America have been cataloguing these things. There are tens of thousands of these stories, and all of them are important. They're all success stories. And these collectively really make up the biggest proof of the benefits of harm reduction, that all these people have managed to quit. Many of them have tried everything else. I didn't, but many other people tried everything else which couldn't work for them, but harm reduction did. So go through some numbers just to put that perspective on it. It's estimated in 2023 there are now around 114 million vapers in the world, and around about 30 to 50 million users of heated tobacco products and pouches. And that's a conservative estimate. We heard there from Delon about Japan, where their sales of cigarettes dropped by half in just 6 years. In America, you may have read about Zyn, which is having a massive take-up in America. That's a nicotine pouch product. And there are about 20 million vapers in the US alone. And just on November the 13th it was, Sweden went officially smoke-free, where it's a prevalence of less than 5%. Their native population is now 4.5%, and it's 16 years ahead of the EU target for smoke-free by 2040. 16 years. I mean, it's an absolute miracle. And yet, we still have incredible opposition as consumers. We aren't listened to. We're excluded from conferences. The WHO refuses to allow us to even speak to them, let alone go along to a conference just to watch. And the reason for this is the WHO says there is a fundamental and irreconcilable conflict between the tobacco industry's interests and public health policy interests. Now, that may have been true when cigarette companies just sold cigarettes, but the whole thing has changed now, and these activists, tobacco control activists, are not really taking into account the new situation with these less harmful products. To give you an example, a bit of a hero of mine, Kurt Enzel, who used to work for Swedish Match, he died recently. He invented the snus portion, which was where snus, a tobacco product which has been pasteurized to remove all the carcinogens, was put into a little tea bag that you could put onto your gum. So you get your nicotine without the harm and the carcinogens of smoking. He invented that product in 1973. And that whole process of Sweden moving on to smoke-free status comes around basically because of his invention. And it's expected that if, it was estimated that if the Swedish model had been replicated all around the world, it would have been, just in the EU, it would have saved 10 million people in 30 years. And yet we have all this opposition. It was mentioned in the report, I noticed, that something I learned quite recently is that one of the biggest studies on nicotine pouches, on snus, was Uragi in 2020. Now, this was a study that was conducted by the Karolinska Institute in Sweden, who are fairly hostile to harm reduction. And it comprised about 420 men covering a total of 9.5 million life years. And they really tried to find a link to oral cancer by doing a review of, I think it was about 9 studies. But they had to conclude that Swedish snus does not appear to be implicated in the development of oral cancer in men. So me, as someone who uses these products, I've seen how my health has improved since I've used vaping and pouches instead. But this is just another pro for harm reduction. Something I wasn't aware of, oral cancer massively reduced because of snus. And I think part of the reason is there's a misunderstanding of nicotine. I mean, I love nicotine. I used to love smoking. I love my nicotine. I don't drink tea or coffee. But I think my drug is nicotine, like many other people's drug is caffeine. That's just what gets me going in the morning, sort of thing. But nicotine isn't in itself harmful. Cancer Research UK in the UK has a page on its website on e-cigarettes, and it clearly states there is no good evidence that vaping causes cancer of any kind. People have safely used nicotine replacement therapy to stop smoking for many years. And yet, countries which use or allow these products to be sold, we've heard mentioned New Zealand, Sweden, the UK, which was good at vaping. The current government's carefully dismantling that, unfortunately. But people misunderstand partly because of these tobacco control groups who don't understand the situation, and partly because of the terrible media that these products get. I'll give you an example from October in the UK. The Daily Telegraph had a headline that said 1 in 3 oral cancers are linked to smokeless tobacco products. Findings raise concerns that the dangers of smoking alternatives has been overlooked. And this article had a picture of it at the top, great big picture of a tin of snus. But then when you read the article, it was talking about cases that had happened in low and middle income countries in South Central Asia, which account for about 88% of these. Through the article, you found it's absolutely nothing to do with snus. It's to do with products that are used in other countries that's got all sorts of hideous things in them, often not even tobacco. So this is what consumers are battling all the time. And we are being ignored. And what's really frustrating is the WHO even has its own charter, the Ottawa Charter, which says that people cannot achieve their fullest health potential unless they're able to take control of those things which determine their health. But there's no control for consumers if we're being ignored. And if all the products which could be very beneficial to our public health are being banned in different countries all over the world. And yet, every single country in the world, you can buy combustible tobacco legally without any problems at all. So I'd sort of just finish by saying it should be really simple with these products, as we've seen with oral health and all other aspects of health, cardiovascular health, lung health, COPD, everything. It should be very simple. A proper risk-benefit analysis of THR products would find their net positive to public health in so many, many ways. But the fact that NGOs, regulators and politicians are not doing that is really nothing short of a global catastrophe, and really that needs to change. Thanks.
Thank you so much. If I could ask Martin and Mihaela to join me in the front, and we'll do a panel, but the panel is really all of us. And I'll just introduce the panel by 2 words on oral health governance. So if you look at WHO, which is an intergovernmental agency, and their policy, you'll find that the 2 most important documents are the World Health Declaration on Oral Health, and then the Oral Health Action and Strategy from 2023 to 2030, where an important statement is made that there is no health without oral health. And what is also important is there are very specific actions recommended to member states, 100 different actions, that if they were implemented, it would most certainly improve oral health outcomes. The sad part, very much like what Martin has just said, is that harm reduction is not mentioned at all. Even though harm reduction methods is part of the Framework Convention on Tobacco Control, harm reduction is not mentioned at all. So that's really what we sit with in terms of changing the world for the better, is just to make sure that we, as all the stakeholders involved, come up with the best narrative and the best strategies to ensure that evidence-based policies are put in place in the different countries of the world. I often wonder what's the scorecard? What would success mean for us as, broadly speaking, healthcare professionals, healthcare advocates, all involved in harm reduction in one way or the other? And if you think of the world as 194 member states, WHO has 194 member states. At the moment, in 37 of those states, the 3 categories, the 3 broad categories of harm reduction products are available. So either in a regulated or in some cases unregulated way. But there are still a number of countries, around 80 countries, where it's more or less banned. So ultimately, if we can get to a point where the majority of member states in most of the 6 regions of WHO at least give harm reduction a chance through well-regulated, risk-proportionate steps to make sure that smokers are incentivized to shift, that would be success. So this is the last part of our breakfast summit, and the idea is that we exchange ideas. I'll start with Mihaela and Martin. Mihaela, you've brought us into the dentist chair when you showed us all the teeth. Tell us practically, when you see patients, people who smoke and who become dental patients, how do you present to them the option of harm reduction? Is there an easy way? Is there a way that is evidence-based, that is more effective than others?
Actually, I think it's quite simple. If the patient is saying, "Look, I would like to quit," this is the yes, because I tried to quit. It's much more simple, because otherwise, what you can tell them, it's just look in the anamnesis, in the oral examination. We are going to do an preventive oncological exam. You know, these kind of words are scary for everybody. So when they hear why is that? Just because you are a smoker, first of all, you are a smoker. And smokers are exposed to this kind of, let's say, changes in oral cavity that leads to oral cancer. And because smoking is bad for you, for example. This is the first line. I mean, always these words, oncological preventive exam, which is very necessary, and it's very good that we have to do it as a dentist all the time. It's part of the oral examination. That it's the first line when you speak with the patient. And from this, you can start doing some other explanation or you can stop for example, doing nothing. I mean, you are doing nothing, because he said, okay, I know, I'm a smoker. So I like to smoke, what can I do? Nothing important. When it comes to the treatment, and they said that the treatment plan means to stop smoking at least for 3 months, just for his well-being and for the success of the treatment, that he's paying a lot, I mean, then the patient becomes more attentive. He will pay much more attention on your explanation. So, and in this moment, you have the opportunity as a dentist to explain how many possibilities he has. So the knowledge of the dentist is very important. If the dentist is aware about what he's explaining, he can explain very nice. But if he said, okay, you have to stop smoking, but if you don't, you are going to lose your implant, you are going to lose your bone, and you are going to lose your money in the end. So this is how, I mean, the approach, we have to make an agreement with the patient.
Yes.
It's a silent agreement. It's something like, we don't have to convince them. We have to inform him how it's going to be if he stops smoking, if he's using alternatives, if he cannot stop smoking, or if he's driving his life as before. So it's just, let's say, we have to earn a little bit the confidence, and usually the doctors are the most trusted person when talking to patients. So I don't think we might encounter a doctor who's not doing something good for their patient. I mean, for his patient, for her patient. It's something that comes naturally when you decide to do this profession. So I think this is, you can see, you know, it's like on the cigarettes photos that you say this might cause oral cancer. Okay, you can show them also some pictures with look how it looks, but you can also show him the picture of his mouth,
Yes.
his own mouth. If you perform some, let's say, images with fluorescent light, for example, it's very easy. You will show it, look, this is something bad. If you stop smoking or if you use something else, in 6 months, you can come again and we will see how it's going to be. So this perspective of coming again and seeing that he's feeling better gives him another point of view on this idea of using something else.
That's a profoundly important point, the personalization
Yes, yes.
for the patient so that they can see this is their mouth, it's their teeth. I thought that your before and after pictures, that works with all of us who battle with fat as well. You know, you want to see yourself. So this is a very important lesson. Thank you for that, Mihaela, is the personalization, especially for health professionals. Martin, from your point of view, how did you get patients and consumers organized in the UK to become such a strong voice? Many other countries do not have that. But how did it start, let's say, 15 years ago?
Well, where I think a lot of it came from in the UK was we were a pioneer really in harm reduction in this country because of David Cameron, the Prime Minister, the Prime Minister we used to have. And he was advised by a behavioural economics unit that you shouldn't just ban these products. They were already being banned in places like Brazil, Argentina, other countries. And he was advised there could be something in this, you know, let's see what happens, don't ban them. So we had a lot of early adopters, consumers who were very passionate about these products, and many of them had tried for years to quit, and they got passionate about the products, pulled them apart, went into their sheds, learnt to make them themselves. Some of them set up businesses. And then the EU came along and said, we're going to make these products medicinal products only. And they were furious, you know. We had a fairly light touch regime over here, and they contacted people in other European countries. And I remember in 2012 going to Place de Luxembourg in Brussels, and we blew up a lot of black balloons with e-cigs save lives on them, and chanted and shouted a lot, got the attention of some MEPs, and managed to fight that off. So there was a lot of passion there, but it only came about because these products were allowed to flourish in the first place, so we had a consumer base to work with. Yes. I'm not sure if that's going to happen again, because the EU is coming up with a revision of the TPD, and they want to fight all those old battles again. And now we really have a more advanced market. So we haven't got those initial pioneers and passionate consumers. We've now got customers.
Yes.
So if we can recreate that again, I don't know. I mean, we're fighting in the UK at the moment. Our government has banned disposables. It's going to be banning disposables next year. It wants to put them in plain packaging, vapes I'm talking about, behind screens so you can't see them, banning all advertising. Basically, they're going to take away all the benefits that we've experienced in this country. And most of it comes from just pure ignorance. And that's not ignorance as in, insulting someone. It's just lack of knowledge and misunderstanding the situation. And this ignorance has been fostered in the last 2 years, in the UK especially, by philanthropists with maybe the best intentions, but are coming out with terrible effects on not just the UK, the rest of the world. And unfortunately, smokers have always been looked down upon by the public, so I think the public see a lot of smokers have gotten away with it. They've quit smoking without struggle, so I don't think people who use nicotine are given much sympathy either. So I think the public generally wants to believe that these things are harmful, and it wants to believe all the ignorance and the poor media. I mean, that example I gave at the Daily Telegraph, that's just one. We noticed as consumers since the very start of 2023, it's been incessant, one negative after another. And I think it's just basically ignorance. But I always say to consumers, we've got a couple here, Maria from Canada over there, and Dr. Rohan, who I know. I say it until I'm blue in the face. Consumers have to stand up for themselves. Write to your MPs, write to your representatives, and make a noise. I mean, I think Maria just delivered 5,000 letters to one province in Canada the other day. Drove there because they got postal strike. That's the sort of thing we need from consumers, because we, at the end of the day, have the most important voice, because we're the most affected in the debate.
Thank you, Martin. Now we're going to do the last 10 minutes questions, and then I'm going to ask some questions of some of the experts in the room.
Good morning. Thank you for your talks. My question is, I'm a physician from Argentina, Buenos Aires. My last name is Messina, Osvaldo and Messina. My talk is directed to Mihaela. Do you have any experience with patients with previous diagnosis of osteoporosis, considering that smoking worsened the osteoporosis itself, but also the oral health and the integrity of the jaw? And this is a problem in patients receiving implants, because the bone resorption is increased, and even more increased with smoking, and the probability of loosening of the implants is very high. Do you have any experience of that?
No, I'm not. I don't have any. I don't have experience in that. Usually, when they have to make implants, these kind of patients are having before another kind of anamnesis, and also they are visiting a surgeon as well. So all the, let's say, complementary information are taken by the other doctor, let's say by the surgeon. And usually we are doing CBCTs to see exactly the density of the bone. But in the end, the decision for performing the treatment, it's not mine. So I am not dealing with this kind of situation. But we can I have a team in Romania with, I'm in this team with the co-author of the report, Dr. Cumpătă. He's an oromaxillofacial surgeon, and I can talk to him to observe exactly what's happening, for example, in this particular case, because we have a lot of persons with osteoporosis, so it might be interesting to see. So maybe next time, with another occasion, maybe we will have some other information.
Thank you, Mihaela. Next question. And please, the question can also be answered by anybody else. I know there's a hidden neck surgeon, and there's Rohan, please.
So thank you. Congratulations, very nice ideas, and I have a lot of thoughts here. I'm a medical doctor also, and a researcher in Brazil, and I'm a professor at the Federal University of Rio. And Mihaela, I'm very curious if the patient, as you said, want to quit the smoking. Do you indicate a professional for them to quit smoking, like a psychologist or a physician, to have the best procedure to quit the smoking, or how do you handle that?
I don't think exactly if I suggest him to go to counseling. Usually, if they decided one time to quit, they tried this, and we are coming just to explain them that it's the best thing for them to quit smoking. And we can also directly see and examine the damage in the oral cavity. So that's how we act, exactly like with evidence. It's like, and I think we can do the counseling as well as oral health professionals. I'm telling you why. Because if you monitor well the patient, and if you tell them, look, you do the cleaning now, if you try to do something good for your health, you can use what kind of product you want, what kind of product you choose, what kind of product is suitable for you, or maybe you can even quit for a period of time, then you can come to me to see again the effects. So monitoring the patient, it's also counseling, because you keep going on with the evidence, with explaining him how good or bad it's the oral hygiene in the next, let's say, 2 months, 3 months, 6 months. So this is another kind of counseling coming from the evidence-based idea, and also coming from trusted information that are coming from the doctor. And of course, I told you, I think they already had this intervention before. It's true that it's good to have a mixture, I mean, between the counseling, psychologist counseling, and a dentist or some other, let's say, doctor. But just only one, it's okay also if you monitor, and if he's keeping coming, and he's keeping his interest in quitting smoking.
Thank you, Mihaela. We have about 5 or 6 questions, so we'll do it very quickly. First, a question to Dr. Kumamaru from Japan. In the report, we cite Japan for its incredible turnaround. From your perspective, how did Japan do it in such a short time?
Okay, I've been asked about this for many years, and actually, the launch of the heated tobacco products started out 2014. It was a test sales, and it started out actively from 2016. So it's less than 10 years. But the consumption of cigarettes has reduced so much, like half, in 8 years. And this phenomenon hasn't produced by any efforts of the government or the medical associations, I would say, unfortunately. But it's mainly the consumers' reaction. Mm-hmm. And I would say 3 tobacco companies' effort. And the only contribution that the government was not to deny the heated tobacco products, because they thought it's just one kind of a tobacco, and it could be less harmful. That's what they think, I think.
Thank you very much. I'm coming around. Your question, please.
This is
or comment.
Professor Amanullah from Bangladesh. The question is, if you see around 200 million people in the country and a good number of smokers, and out of those smokers, still a considerable number of the chewy, the different type of tobacco products, like it's locally known as the raw tobaccos. Jorda, they called it a huge market. They're not smoking, and they don't know anything about the vaping products or anything. they don't have the capacity to buy the vaping products, or the availability of vaping products in the local market is also is a far cry. So there is a big question that how to reach and cover those population with the THR. It's one question, and another question is it's very tough to convince the policymakers about the THR. So if there are some attempts to hold some meetings, something like this within the ground, like in Bangladesh or in other parts of the South Asia, we could host those programs. That would be much more helpful for the policymakers and us to convince the policymakers and the lawyers in this regard. Thank you.
Thank you very much. From moving from Bangladesh to Mumbai, India, and Dr. Rohan Sukwira, our cardiologist.
Hi, I'm Dr. Rohan Siqueira, half Portuguese, half Indian, so I'm stuck between two places. Hi, Martin. Okay, I just want to, give a reply to that very interesting question from Argentina about, since I'm a cardio-endocrinologist, we do both cardiology as well as endocrinology, so that question is really, really very apt for this kind of a situation. The effect of cigarette smoking on bones is something which is often neglected and something of very, very high consequence because especially where I practice medicine in India, that's in Mumbai, as well as in Portugal. But we don't see the amount of osteoporosis or osteopenia in Europe as much as it is in India. The reason being is that most of the smokers in India use oral tobacco, like Dr. From Bangladesh, I'm sorry I forgot his name. Nicotine and smoking, both combustion and non-combustion, has got 5-fold actions on bones. Number one, it reduces a cell that produces bones called osteoblast. Direct consequence, it causes the bone production to drop significantly. That's why when people go for implants, the first thing they tell them is to stop smoking. Secondly, it reduces the blood supply because nicotine or combustion using vape, even vape products, even oral nicotine, can cause vasoconstriction. So your blood supply to the bone reduces. Those are the 2 direct effects, but 3 indirect effects which can cause osteoporosis or osteopenia is number one, it causes a hormonal disbalance. You have a change in the estrogen levels, even in males. You have a change in the parathyroid hormone, which regulates the bone, right? And also it causes oxidative stress. Now, if you look at the difference between oral nicotine, combustion nicotine, or even those which are used by ENDS, there is a very big spectrum where the highest impact is by those using unfiltered tobacco, which is oral products, people using cigarettes, which is combustion, pipes, or all forms, even shisha and hookah. Those all come in the red spectrum. But as you go according to the THR spectrum, which is the more inclined you are towards THR, the effects drop. So that is something which I just thought, since you'd asked that question about bone health.
Excellent answer. Professor Sharifa, in Malaysia and in Southeast Asia, what would you say would be if you had a magic wand, what would you do to help change around the situation so that harm reduction is introduced into tobacco control?
Thank you very much. I'm Sharifa from the National University of Malaysia. I'm a public health physician, a medical doctor, and also a researcher as well. I've seen a lot of familiar faces as well, Martin and so on, and colleagues and all. I think one of the biggest problems in Malaysia is because we have an influx of not only cigarettes but also illicit cigarettes, but also a black market, a huge black market. So that is one of the many impediments for the introduction and also propagation of THR. So the policymakers keep coming up with things like the vape causes some drugs being infiltrated into the e-juice and causes a lot of psychosis among the teens and so on, because it's very poorly regulated. The second part is that most of the policymakers, including the governments, are very much dictated by the WHO, FCTC. Most of them are signatories to WHO, and they really read this as a Bible. So you cannot say that, they keep saying that, okay, if you change or you switch to ENDS or THP or heated tobacco products, in the final results, it's still tobacco. because they presume or they equate nicotine as the same as tobacco. So that it comes to a halt because you can't, you can't discuss with them. It's an end point. And I think same with Bangladesh. We have a problem of black market as well. And it's very difficult to influence the policymakers. We keep giving out reports and asking experts, but they have now come up with some laws. I think it's a blanket law that many countries have also experienced, is that you can't talk about THR anymore. You're not supposed to talk about THR. You're not supposed to educate people on THR and things like that. So that hampers a lot of activities in some of the lower middle income countries, LMICs. And we are having that problem as well. I was just about to ask Martin, how do you actually move on when that sort of ban, you still allow, but you're not supposed to talk goods about THR. Thanks.
Yeah, I think that's the case in India as well, isn't it? Research into harm reduction products is banned, which is, I mean, that's profoundly not just anti-science, it's anti-civilization, isn't it, basically? But I'm constantly surprised by the amount of excuses that governments come up with in many countries. I mean, just in my country, last week there was a debate. I was just holding my hand. Some of the ignorance these MPs were coming out with was astonishing. It really was. And our Secretary of State for Health actually said when he was told, if you're banning these products, if you ban flavours, if you ban disposers, you're going to end up with a black market. He said, oh no, that's a lie. That's a tobacco industry lie. I mean, this is our Secretary of State in a country like the UK, which is a Western nation considered to be quite civilised, and he's saying this is a lie. If you ban things, you don't get illicit markets.
Martin, I just want to quickly make sure we have 2 more questions. We have 5 minutes left. I want to introduce you to Tiki Pang, who many of us who worked with WHO and in WHO over the years saw as one of the absolute gentlemen of health diplomacy. And he was so effective to persuade governments. So, Tiki, from your perspective, what can be done to influence positively on an evidence-based way WHO, and how should advocates like ourselves engage with member states?
Yeah, my name is Tiki Pang. I work for the World Health Organization in Geneva for 13 years. In relation to what Delon said, what magic wand do you need to change the attitude in those 37 countries? Just 2 quick points. I think Sharifa has already mentioned. In many of those countries which lack the scientific capability to evaluate evidence, within their own context, they look towards the WHO. If this is what WHO says, we just follow. So that's the first point. The second point is many of those countries, we did not have a David Cameron. We did not have the vision of a nudge unit. And we did not have the Royal College of Physicians or formerly the PHE, highly respected scientific bodies that the government listens to. So the second point is really about leadership. The point about how do you change WHO's mind, the only thing that can change the position of the WHO are the member countries. And I've said this in many fora. Progressive countries like the UK, like Japan, even smaller countries like New Zealand, for example, Sweden, if they collectively go to the World Health Assembly and say, we want you guys, COP21, FCTC, World Health Assembly, to be more open, to be more inclusive. As you said, Martin, consumer groups, tobacco companies, which I believe are part of the solution, they're not even allowed to attend any of these meetings. So it's the only thing that can move WHO are the member countries. I'll stop there.
Thank you for those words of wisdom. And now we go to an Argentinian Pole, or Argentinian who lives in Poland with Polish babies. Federico.
Thank you, Dylan. Thank you very much for this event. My question is for Martin, because I've always been afraid of the dentist. Sorry. So, Martin, very quickly, the UK is a major success case of innovation, solving a problem, but now it seems that we're seeing some sort of counter-revolution. So my question is, what went wrong and what can we do to solve this problem before it gets worse and worse?
Well, can I just mention what Dr. Tiki said? He's absolutely right about the WHO and these COP meetings. And consumers, we're trying our hardest to sort of get consumers all over the world to write to their governments and say they've got to stand up against the WHO. I was quite encouraged at COP10 that news was that around 30 or 40 countries did stand up to them. So I'm hoping that should encourage more countries to do the same in Geneva in November next year. Yeah, what's happened in the UK, it's just an object lesson in pressure on governments. Because like I said, it was almost from the 1st of January 2023, just negative stories started appearing in press. And it was every single day. And if you just keep pumping that negativity, people are going to start to believe it. I mean, I remember one day that the Daily Mail had 3 anti-vaping articles on one day. And we know this is coming from, you know, the people we know, Bloomberg and Gates and those philanthropists. We know that's where it's coming. The money started to flood into the country around about January 2023. And over time, politicians have just been convinced that these things must be bad. But then, like I said, I think they wanted to believe that anyway, a lot of them. Some of the things they're saying in Parliament last week was just laughable. I mean, one woman said, a woman MP, she said, I think it's great that young people are quitting smoking so much. It's brilliant. We're down to record levels. But they're all vaping. And she can't seem to put in her mind that these things might be linked and that it's a public health net win. You just can't because every article, the start of it would say vaping is much less harmful than smoking, but it still contains nicotine. And that's the problem, is that there's a misunderstanding between harm and nicotine, which is not particularly harmful. And we need to somehow get that message across. I don't know how we do that, because we're trying, but not with much success.
Thank you, Martin. Last question, and then the last word will be by the dentist, Mihaela. Yes, sir.
Good morning. Thank you for your exposition. My name is Fabio Beatrice. I came from Italy, Turin. I am a head and neck surgeon specialized in head and neck cancer. So I'm very interesting to your relation. I think that we have 2 big problems, one top-level problems and one down-level problems. The top-level problems is that many governments in the world don't understand really potential of harm reduction, and they think that harm reduction is a risk for young people to start smoking. But it's a really big mistake. I think that the nature editorialist explain us very well that there are 2 different problems. To block the start in young people for smoke, and to help hard smoker are 2 different questions, and I think that need different position in the government in the world. The down level is what we say with patients when they come in our ambulatory. It's possible, for example, before counseling, use some simple questionnaire, self-questionnaire in waiting room about nicotine dependence, test Fagerstrom, motivational test, simple motivational test, 5 questions, and a very brief ask about pathology, how many cigarettes you smoke. So when you speak with patients, you have just some information about effect of nicotine, about the really possibility that they quit. We need perhaps really a procedure, some rules. So it's possible that every people in the world, if we give some rules, follow these rules, and the information is more selective and more homogeneous.
Homogeneous.
Homogeneous, yes. Sorry for my English.
No, it's beautiful, the Italian accent, and it's a short question, because we need, I know many of you have to leave. There's a hard stop.
Short comment. Frequent clinical scenario is it's a woman, postmenopausal woman, thin postmenopausal woman, who consumes tobacco and a lot of coffee. And she has a severe osteoporosis, and she wants to make an implant. and she is receiving bisphosphonates for osteoporosis, which worsen the situation and produce ONG, osteonecrosis of the jaw. See, this is the most clinical scenario. I fully agree with the colleague from Mumbai, where the situation is much worse than all the medical community think about. So I fully agree with you, and I think that it's a neglected issue, and it's very important to pay attention to this situation, which is very frequent in clinical practice.
Excellent.
Yes, it is true. I fully agree with the doctor as well. But I told you that usually these cases are especially treated by the surgeons. And about the rules that the doctor from Italy told us, this is why we are doing this report. This is the call for action, to find a solution and to find some idea, to find a way to make it better. This explanation for the better oral health. So the report has this aim also to find some, let's say, not rules exactly, but to find exactly the find of communication with the patient to be sure that the patient understand exactly how wrong is it and how he can change it in his benefit. So that's why I think, therefore, we cannot ignore the oral health, and we cannot ignore also the general health, because all the time we have to see a holistic image of our body.
Couldn't have finished our session on a more appropriate note. So as Mihaela has just said, this is unique because it's the first publication of its kind. It's connecting the dots between the mouth, smoking, and harm reduction to switch smokers away from cigarettes. And it's just to start the conversation. And I can't thank you enough, the rich comments from all over the world, from east to west, here in UK, to hear what David Cameron did and didn't do, and to see that all of us are actually brothers and sisters in arms, and that our oral health can be one of the easy, low-hanging fruit that we can use to really push for harm reduction to be integrated into tobacco control. So thank you very much on behalf of the Oral Nicotine Commission for your presence here today, your participation. Please, let's make this the beginning of the conversation and not the end. And what we'd like to do now is just invite you, there's some tea and cake just for your teeth down below. And I know some of you have to go to the next event, but we thank the speakers and we thank the authors of the report.